Good morning, everyone. Sorry, I'm clicking around, making people co-host. That's why I look like I'm concentrating very hard because the list keeps growing and the co-hosts keep scrolling away from me. Okay, there we go. Good morning, everyone. Good afternoon. Good evening. It's Tuesday. It's Neurology Morning Report, and we're so excited to see everyone. We hope somebody has a neurology case to present, and we would also like two discussants to discuss that case with us. And if you're feeling hesitation, I have to teach the first year neuroanatomy course at my institution the next 3 weeks. So there will be no neurology morning report for 3 weeks. So if you were thinking I was going to wait maybe one more, today is the day. Otherwise, it'll be 3 weeks until we have another neurology morning report. Who would like to present a case and who would like to discuss? Somebody must have a case and two people must want to discuss. Anyone? I have so many cases, but it won't work if I present them to myself. That defeats the purpose of the unscripted case conference. Nalayan, you'd like to discuss? Thank you very much. Great. So that's one discussant. We need a case and ideally a second discussant identifying as a woman. Who would like to present a case? I know somebody has a case. I know someone else wants to discuss. We need a case and we need a discussant. Please, please. I will sit here and maintain awkward silence. And then people will say at the end, it went over again. You set the record for the longest morning report. Anyone? Great. Valeria has a case. Don't worry, a little short. I promise I'll make it long. I'll make it long. And then that's wonderful, Valeria. Thank you. And we would like someone, ideally someone identifying as a woman, to co-discuss with Nalayan. We are 2/3 of the way to beginning. Who would like to join this discussion? Get your fill of neurology. Who would like to discuss? I will rock in my chair until someone joins. Nalayan. Okay, great, Maria. Good idea. So if Valeria and Nalayan want to introduce themselves, and their inspiring presences will surely inspire someone else to want to join them.
Yes, I can go first. Hello, everyone. I'm Valeria. I'm from Peru. I have presented a couple of cases here before in Neuro VMR. This one is a little short, but I'm sure the discussion is going to be very rich as always, and super excited to hear you discuss. Please volunteer because honestly, I've been in the position that I felt very nervous to discuss, especially Neuro VMR, but I've learned so much, so I can't recommend it enough.
Great. Thank you for that plug, Valeria. We're excited for your case. And as you have appropriately written in the chat, TB or not TB, since Valeria has presented two contrasting tuberculosis cases. So we'll have to decide if it's to have recency bias or to avoid such heuristics. Okay, we need a second discussant to discuss with Nalayan. Nalayan, why don't you introduce yourselves, and people will be so excited to meet you that they'll want to discuss with you. Let's try that strategy.
Sure. Hello, everyone. My name is Nalayan. I'm a final year med student from New Delhi, India, and I'm really excited to be here. I'm discussing Neuro VMR for the second time and overall third time. I'm very, very excited to be here.
Great. Thank you, Nalayan. Okay, we're waiting for another discussant to discuss with Nalayan. Shubhangi, I don't think you've ever discussed a neurology case. No?
Hello, sir. Yes, I have never discussed. I'm fairly new to the group. I recently had my first time on discussing a non-neuro case on a Saturday itself. So, hi, I'm Shubhangi, and this is my first time on discussing a neuro case. And full disclosure, yes, I have a neurophobia, and so I think best thing to do is just jump right in and just wade through your fear.
Fantastic. And tell us, where are you joining us from? Since we haven't, I know you've met others here, but I don't
Yes.
think I've mentioned.
Yes, I am from New Delhi, and this is my second VMR of the day. Time zones are amazing.
Yeah.
So,
Wow.
we had one VMR for me at 5 a.m. in the morning, and then again at 9:30. So enjoying it.
Thank you so much for our friends and colleagues in India for joining us at all hours of the day and night. Fantastic. Well, so excited to have you discussing your first Neuro VMR. I'm sure you're not the only one here with neurophobia, and the goal of this is to reduce your neurophobia and in the process that of everyone else we see in this checkerboard of participants. So great, Maria and Chiara are going to be doing scribing and teaching points. So Valeria, if you'd like to give us just the chief concern, just the chief complaint, we'll get off
Yes.
to the races here.
The chief complaint is frequent stumbling.
Frequent stumbling. Okay, Shubhangi, what would you do with this chief concern? It may be a little different than some of the other VMRs. So I like to start with just as few words as possible and think about how we would begin to respond and think about our approach to this chief concern.
So frequent stumbling. First of all, with respect to stumbling, if the patient comes to me, I would immediately notice their gait. Like general physical examination would end up happening much before I start taking the history. So over there, I would notice what kind of gait it is and how old the patient is also, because more often than not, it is their eyesight leading to frequent stumbling, and they have a lot of disabilities. So if I put those practical aspects outside, I would, there could be a neuropathy, which is leading to a frequent stumbling, like a peripheral lesion. In terms of a central lesion, it can be a cerebellar lesion. Frequent stumbling can be because of some muscular contracture, which has already taken place. So I would like to ask for a past history for that. If I have to see, if I have to differentiate between something peripheral and central, peripherally, I would ask if there is any radicular a root pain, or if there's any sensory loss in the dermatomal distribution of that nerve. If there's any numbing. In terms of a cerebral lesion, I would like to see if with respect to the examination, if there's any pass pointing, or if I do the shin heel test, if it is abnormal. I would also like to check for nystagmus. I would ask if there are any associated vestibular signs. Yes, we left out the vestibular system. Vestibular system can often lead to a nausea, and so the patient can have a vertigo and can lead to a stumbling. So that's
Brilliant, fantastic. Oh, keep going. Yeah, please.
That's all I'm thinking. Maybe we would come more.
Yeah, that's fantastic. So right, we have a problem with gait here. And as you brilliantly laid out for us, Shubhangi, gait is such a complex function that we have that is not really learned in the traditional way where someone teaches it to us, right? It's just an acquired function that we have and requires essentially every aspect of the nervous system, right? So we often check gait last: mental status, cranial nerves, motor, sensory reflexes, cerebellar, and gait. And sometimes it's not really clear to us what the problem is on those first 6 parts until we see the gait, because gait is really a stress test of how well each of those systems work individually and in concert, right? So as you said, starting from the top, we could have visual problems that could lead to difficulty with gait, and those could be ocular problems, or those could be visual cognitive problems with spatial perception. There could be higher order aspects and what I call the gait app, to use a modern metaphor, right? Whatever parts of the frontal lobes are coordinating the whole aspect of cerebellar motor sensory and then patterning this rhythmic movement of gait. So that's why we can see problems with gait and normal pressure hydrocephalus, presumably due to some type of stretching of those frontal fibers. Some people call that a gait apraxia. And some people say that's not an appropriate use of the term apraxia, which is supposed to be loss of learned movements. And we don't technically learn how to walk. We just sort of naturally develop that skill. Right. And then what is that gait app using? Well, it needs to know, as you said, the proprioceptive information from the sensory system that comes from the peripheral nerves into the spinal cord and up to conscious perception in the parietal lobes, and then subconsciously arrives at the cerebellum for its proprioceptive input, right? And then the brain needs to send a motor output, right? And that motor output both needs to move muscles and be coordinated by the cerebellum. So essentially every aspect of our nervous system, right, is working together in this symphony of functions to allow us to walk normally. And as you mentioned, depending on if this is truly a sort of gait problem, we could even have non-neurologic problems, right? There could be orthopedic problems, like a knee problem, a hip problem, some type of arthritic problem. And there could be a local problem in one of the feet. There could be a foot drop. You mentioned there could be an ankle contracture from some prior injury. Valeria said it was a short case. If this is just an ankle contracture, it'll be a really short case, but I don't think it's that short, right? So we'll want to know a lot more about what the stumbling is. Is there associated dizziness, vertigo? That was a great thought. Is this a vestibular problem? So we've really sort of checked off any potential place on our map of the neuraxis where a problem there could lead to gait, because gait is such a complex function. It's interesting, my brother just had a baby. I haven't gotten to meet her yet because of COVID, and he sent me a video of her starting to learn how to walk. And I hadn't ever seen a baby walk as a neurologist from this perspective. And she had a very wide base, kind of magnetic gait. She had both of her arms flexed. And I said, this is what the gait looks like in people of older age who have sensory systems failing or have NPH. And I thought, oh, because she's not fully myelinated, right? Her frontal lobes, her nerves. So her gait is the stress gait of someone still sort of feeling out how this works, just like Babinski's sign goes away and then comes back later with dysfunction. So I thought that was very interesting to watch this video of gait and say, if an adult looked like that, I would be localizing here, and seeing how it's such a complex function that's built up through sensory function, coordination, motor function, higher level motor planning, visual system, etc. So we could really be anywhere, and that's you got us off to a great start, Shupangi. So with that in mind, Nalayan, as we hear this history, are there particular questions that are on your mind that you're going to want to find out the answers to as Valeria is presenting, that are going to help us begin to start to localize even with the history?
Well, as you have mentioned plenty of times, in neurology, we have time course into localization, right? So first, I would like to know the age of the patient, because some problems are really more common in old age. For example, the non-neurological causes, as mentioned, for example, osteoarthritis. A simple osteoarthritis can cause gait problems and frequent falls. So my first question would be age. Second would be to rule out the non-neurological causes, something like peripheral skeletal, musculoskeletal causes, and to rule out vestibular causes as well, right? And third would be to localize. As you have said, gait is a diffuse process, and we examine it last. So I will have to do a detailed motor sensory examination to essentially localize what and where the problem is. In terms of history, not much. I mean, not much.
Not much. Okay, great thoughts. Right. Yeah, the exam is going to be very key here, as you said, because we'll want to see, well, if the patient has weakness in the legs, that has its own localization and differential diagnosis. And maybe the gait problem is that there's weakness despite preserved coordination and sensory function. Or maybe there's preserved strength, preserved coordination, but impaired proprioception. So we'll definitely be teasing those apart on the exam. And then I mentioned normal pressure hydrocephalus as being a higher order function of gait, what some call a gait apraxia. And one of my mentors showed me this amazing test you can do if you've seen a patient with NPH, normal pressure hydrocephalus. Try to walk, as you know from studying for the boards, right? It's a magnetic gait, which means the patient sort of brings their foot up and then quickly brings it back down, and it sort of has a sort of shuffling characteristic. But if you have the patient lie in the bed and then just bicycle their legs they do it with complete coordination, fluidity, and normal rhythm. So it shows you this is truly a problem with the higher order control of gait, even though you can do other patterned dexterous movements with the legs. So as Lion was saying, when we see the gait, sometimes all those other functions are normal. And we say, well, something's not right with the gait. We can even localize further at that time. So the time course is going to be important. As far as historical aspects, if the patient just is telling you that there's difficulty walking or that they've stumbled a few times, what are some questions we might ask? You could ask, is the toe sort of getting caught on the carpet in these things? Some patients with a foot drop, since you can't dorsiflex when you walk, the toe will be sort of tripping over things, and they'll feel they have to lift their leg up higher so they don't trip over the front of the foot, the toes. You could ask, is it worse going upstairs or going downstairs? Upstairs requires a lot of proximal motor strength. For example, we'd want to ask if this is really a sort of consistent problem or it's in particular environments. People with poor proprioception, when they're in the dark, they're more likely to stumble. That's sort of a real life Romberg test, right? Because they're in the dark, and just like having your eyes closed during the Romberg test, you remove vision, you have to rely on proprioception. So older patients, for example, with visual difficulties may report that their falls are more common at night when they get up to go to the bathroom or in the shower. They close their eyes to wash their hair or whatever, and they have slipped in the shower. One of my mentors, Marty Samuels, who some of you have seen teaching in these monthly conferences, used to call the shower a Romberg machine. He said this is a place where so many patients fall, right? And it's from the Romberg phenomenon that their proprioception is poor, they're compensating with vision, and they close their eyes in the shower. It's slippery and to begin with, and he calls it the Romberg machine. Okay, great. So I think anything remains possible. So we'll hear from the history, if that helps us sort of put things in one of these localization categories as far as the type of gait problem leading to stumbling. And if the time course piece allows us to think a little bit more about etiology. So great discussion, Shupangi and Nalayan, and Valeria, let us know a little more of the history, if you would.
Okay, great discussion. So the history, it is a case of a 47-year-old man that presented with a 3-year-old history of frequent stumbling and progressively increasing weakness in bilateral lower limbs. 6 months before presentation, he referred constipation and nocturia. And he also, most recently, the past couple of weeks, refers erectile dysfunction. That's why he actually came to consult. And he denies any weight loss or fever. Would you like me to give you some of the PMH?
As you wish.
Okay, so I can tell you that he had a coronary bypass surgery a year ago, and he was diagnosed with hypertension 7 years ago. That it's been treated with aspirin, atorvastatin, and enalapril. And 4 years ago, he received treatment for a parasitic infection, but he doesn't remember the name of the organism. I mean, he actually came from the Andes to Lima. And from family history, the only relevant fact was that his wife was diagnosed with multiple sclerosis 5 years ago. His
wife, okay. And then after constipation, did you say nocturia, or what was the, so I didn't just nocturia?
Yeah, 6 months before presentation.
Okay, so 3 years of progressive walking / weakness problem, and then in the past months, this constipation, nocturia, and erectile dysfunction. Is that right? Okay, Nalayan, what do you make of this history?
Yeah, so we have stumbling, we have lower limb weakness bilaterally, we have constipation, and we have erectile dysfunction, and no history of weight loss. So let's break it one by one. So when we think of stumbling, we think of gait disturbance, and now we know that there is a bilateral lower limb weakness as well. So we can localize the gait abnormality to either nerve or muscle or the neuromuscular junction. Because we know the cortex can be involved, but given the fact that the patient is experiencing weakness in bilateral lower limbs, we can localize it to these three buckets: nerve, a muscle, and neuromuscular junction. Now we know that it's bilateral. For a muscle to be affected bilaterally is less common than a nerve to affect them. I mean, it can obviously be a myopathy sort of, but I will be thinking more in terms of nerve. And then my question would be: is it a lower motor neuron or an upper motor neuron disease? Now the fact that the weakness is bilateral, but points to more towards an upper motor neuron sort of pathology, and not a lower motor neuron pathology. And but I will still like to know if the patient is hypertonic or not, if they are reflexes or not. If there's a hyperreflexia clonus, that. And well, the fact the patient has constipation and erectile dysfunction points to an ANS pathology, that is autonomic nervous system pathology. So there's, I'm not very sure how to amalgamate these all findings, but yeah.
Yeah, great thoughts. So I want to pick up on something you said, the weakness is bilateral, and you were using that to localize. You said that would make the brain very unlikely, and largely that's true if there's no cognitive disturbances, right? The idea that you'd have bilateral brain lesions causing bilateral weakness is relatively unlikely. Sort of what I call gourmet neurology, right? You can rarely get a midline lesion. Remember, the leg areas of the homunculus are very medial, the most medial structures. And those leg areas of the homunculus, if you remember that figure sort of dangling over the homunculus right into where the falx cerebri is. So you can very rarely get a parasagittal meningioma that can expand and get both leg areas and cause a cerebral paraplegia. It's very uncommon, or bilateral ACA strokes. But otherwise, I agree with you. The brain is generally unlikely for bilateral paraparesis. The brainstem is very unlikely, right? Because you would expect to see cranial nerve involvement, and the arm and leg fibers are there together. So we're really sort of spinal cord and below. And if we don't have the arms involved, then we're probably thoracic spinal cord and below. And so, as you said, that means we're either in the cord, the nerve roots, the nerves, the neuromuscular junction, or the muscle, which is still a lot of territory to cover, right? And so I think the question to ask here is, if those are all possible, and as you said, if the exam shows us upper motor neuron findings, that simplifies our lives, right? We're in the spinal cord. If it shows us lower motor neuron findings, we're in the roots or the nerves. And if it doesn't show us any change in the reflexes per se, we could be in the muscle or neuromuscular junction. So I think the question is, can we use that autonomic, these autonomic features to help us localize along this axis of thoracic cord and below? Any thoughts on that, Shupangi or Nalayan, as far as integrating this initial excellent localization from Nalayan that we're probably thoracic cord or below, and using the autonomic information to potentially help us with that?
Yes, I was thinking along the same lines as Nalayan, although he put it down very lucidly for all of us. And I was thinking maybe there is a spinal canal lesion, if there is an outer pathology which is compressive, or a cavitatory lesion which is taking place inside. And because it is a progressive bilateral weakness, we can maybe think about that. I would also like to know if there's any associated sensory loss in the bilateral lower limbs.
Yeah, how will that help you? I agree.
Dysfunction.
The sensory. Oh, I'm sorry. Go ahead. Go ahead.
I'm sorry.
I was just. Yeah. Go ahead. Go ahead.
He also had a CABG 1 year ago. So that makes me think if so atherosclerosis also leads to autonomic dysfunction if not taken care of, or if it is chronic. So maybe that is causing it. I'm just sort of thinking in all directions right now.
Yeah, great. One thing I wanted to pick up on that you mentioned is you said you'd be interested to see if there's sensory changes, either that the patient reports or that are found on exam. I agree with you. How will that help as far as this localization between cord, nerve roots, nerves, neuromuscular junction, and muscle? How would the sensory exam help you? I agree with you. Are you able to describe a little further?
Sensory exam in terms of...
Oops, you got muted somehow. Sorry.
Hello.
Yes.
Yes. So I would like to ask if there are positive symptoms, if there is a lancinating or shooting pain. So it is just at the entry of the nerve in the canal. The S2, S3, S4 can get compressed and cause the erectile dysfunction at that point. And so along that.
Yeah, great points, right? So is this just a motor problem or is there a sensory problem? If there's motor and sensory together, that would take out muscle and neuromuscular junction, right? That would put us either in the nerves or the spinal cord because there are both motor and sensory fibers in both of those. Whereas if you had a neuromuscular junction or a muscle problem, right, you shouldn't have any sensory dysfunction. And then we come to these autonomic features, which, as you said, localize essentially all to S2, S3, and S4 that control the sphincters. So we'd want to know if there is saddle anesthesia. And we can even ask during the history after you go to the bathroom and wipe, do you feel the sensation of the toilet paper? Do you feel the sensation of going to the bathroom? Those can be clues to whether there's saddle anesthesia. So that's something we could ask about. And then in general, I would say if you see bilateral lower extremity weakness, right, you're not worried about the brain because there's no cognitive features, and you're saying it's spinal cord, cauda equina, roots, nerves, neuromuscular junction, muscle. When you see the S2, S3, S4 sphincter kind of dysfunction, usually that's going to be cord or cauda equina. Once you get into the peripheral nerves and peripheral neuropathies tend to affect the longer nerves, right? And those are very short nerves from the cord to the sphincter. So if you think about it, even in the very severe cases of Guillain-Barré, you may have seen generally there's not sphincter dysfunction with those in that neuropathy. And most neuropathies are very severe neuropathies. Interestingly, even ALS, motor neuron disease, often the sphincters are spared until very late, believed to be due to sparing of, I believe it's called the Onuf's nucleus or nucleus of Onuf, for some reason is spared. So those signs in coordination with in conjunction with the bilateral lower extremity weakness make me think more of the cord or cauda equina. If you had just the lower roots of the cauda equina, you shouldn't have weakness, right? Because S2 through 4 are just doing the sphincters, and the legs are L2 through S1, a little bit of S2 for plantar flexion, but not this degree of weakness that we've heard about. So I think that puts us, to me, more in the spinal canal here. What to do with these other aspects? Well, gee, a cabbage at 47 and hypertension at age 40, that sounds very advanced cardiovascular disease for such a young age. How to incorporate that here? If there's a lot of atherosclerosis in the coronary vessels, there can be atherosclerosis elsewhere, right? For example, the aorta. And could this patient have aortic atherosclerosis that's been progressive and led to spinal TIAs? These are uncommon, but occasionally patients with very severe atherosclerosis can have spinal TIAs where they stumble or fall and can ultimately infarct the spinal cord. Usually that would be a sudden event, but if there's just sort of ischemia without infarction, perhaps it could present like this. I'm not sure I have another way of correlating the cardiovascular disease with what we think is going to be a spinal cord or cauda equina issue. The parasitic infection, hard to know what to do with that, right? To either of you, just for fun, I'm not sure it will fit with this differential Nalayan or Shubhangi parasites that you think of that could affect the cauda equina or spinal cord. Any come to mind?
I can think of none.
Yeah, okay. I'm not sure if you have in India schistosomiasis, and I'm not sure if you have it in Peru, but for patients who swum in fresh water, you can get schistosomiasis. There can be an acute pulmonary and dermatologic sort of reaction to the parasite. Lives in snails, I believe, in fresh water. And it can also cause an acute myelopathy, usually not chronic like this, but you can get spinal schistosomiasis, usually causes an acute myelopathy or a cauda equina syndrome. Really, any parasite can find its way back there, but that's the common one. Neurocysticercosis we almost always see in the brain. You can get spinal neurocysticercosis. Patients most often have simultaneous brain lesions, but it has been reported. And then some of the really rare parasites, you can find these dramatic case reports of big parasitic abscesses in or around the spine. And then, of course, Valeria has presented us 2 tuberculosis cases in the past, and patients with a new spinal problem, sort of this acute on chronic, subacute on chronic, acute on subacute in a TB endemic area. For a non-traumatic myelopathy, TB would be certainly very high on the differential diagnosis, right? Either causing Pott's disease, we might expect some back pain and a spinal deformity, but you won't always see it, or spinal meningitis, arachnoiditis, or tuberculoma. Even if Valeria hadn't presented 2 TB cases in a TB endemic area, we would have to think about this, right? And there are studies looking at non-traumatic myelopathy and TB endemic areas, and I think patients over 50 or so, the top diagnosis is metastases to the spine or spinal column, and below age 50, the most common is tuberculosis of the spine. Studies, I believe, in Malawi, but also some systematic reviews. So great. So I think we're going to go into this exam very interested in trying to localize this a bit further. So other thoughts before we hear the exam, Nalayan or Shubhangi, and otherwise, what are you most interested in on the exam to try to narrow down the localization here?
Do you want to go first? Or should I go?
Either of you has any thoughts, feel free to go ahead. Yeah.
I would first of all like to localize now that there is a high suspicion of spinal cord and involvement. Would like to go forward with the sensory exam and also see because he came with a stumbling, see if there are any other signs of a vestibular dysfunction. Then I would also like to see if at all there is if at all I would like to localize the level of the lesion by doing a nerve exam. There would be a band-like sensation if he points out an upper motor neuron lesion over there, or like a lower motor on that level, and then upper motor are down there. So that's what I would like to do.
Fantastic. Great thoughts. I agree with you. We want to see if there's a spinal level, right, which you can use by using a pin, or if you have a reflex hammer that has that sort of sharp point on the other side, just going up the spine and see where the patient feels it. And if there's a clear sensory level above which the patient feels that and below which they do not, the level of the lesion is generally within 1 or 2 spinal levels there. So that can be a very helpful test. Absolutely. And then by the pattern of weakness, right, that can help us localize to a myotomal level. Okay, Nalayan, what are you looking for in particular on the exam here?
Okay, I just want to look at reflexes and the pattern of weakness as you just mentioned. Just to localize if it's upper motor or lower motor neuron, that would help us narrow down our differentials to some extent.
Yeah, and tell us, for those who might not know or might be trying to remember right now, as you say, how would you use the reflexes to distinguish upper from lower motor neurons lesions?
Okay, so in lower motor neuron lesions, we would typically have a flaccid type of weakness and a hyporeflexia, because a reflex arc cannot be completed. In an upper motor neuron pattern of weakness, we will have a spastic type of weakness and hyperreflexia or clonus.
Right. Yeah, the mnemonic I like to use is upper motor neuron lesions, everything goes up. So you get hyperreflexia, increased tone, upgoing toe, right, as the Babinski sign. You can get clonus as well as sort of an extension of hyperreflexia. And lower motor neurons, everything goes lower. Hyporeflexia, decreased tone, and the thing that doesn't fit, you can see fasciculations also, which are increased muscle twitching with lower motor neuron lesions. So I agree. If you told me I had a patient with paraparesis and I can only do one thing on the physical examination, I would want to do the reflexes, right? And decide, is this central or peripheral? The other thing with regard to the pattern of weakness, there is actually a pattern that fits with upper motor neuron and lower motor neuron as well. So when you have upper motor neuron lesions in the arms, the flexors tend to be stronger than the extensors, and the opposite pattern in the leg, where knee knee flexion tends to be weaker than knee extension. How can you remember that? Well, if you've seen a patient who's had a stroke a long time ago, on one side, they're walking with their arm held in flexion, right? And the leg is held out in extension with the foot plantar flexed. Presumably nature, evolution allowed that compensation for injury, because if it was the other way, with the arm extended and the leg flexed, wouldn't be able to walk and wouldn't be able to eat. That's how somebody explained that to me. I don't know if it's true, but you can use that pattern of spasticity to remember that the arm is because the flexion was stronger than the extension, and the leg is an extension because the extension was stronger than the flexion. So if you examine the legs and see that bilaterally they're weak in knee flexion more so than knee extension, that can be a clue to an upper motor neuron pattern of weakness. The pronator drift is part of this family as well. I can't sort of get in the camera there, right? But the supinators become weaker than the pronator. So when the patient closes their eye, the arm starts to pronate, the fingers start to flex, and that's again flexion sort of being stronger than extension in upper motor neuron lesions. So sometimes even the pattern of weakness itself can help us with upper versus lower. Right, so we'll want to confirm, as Shubhangi said, there's nothing going on above the neck that would lead us away from thoracic cord or below. Nystagmus or other things that you mentioned to tell us this is a vestibular problem, though we haven't heard about dizziness or imbalance per se. So some patients may say that they're weak, and actually they're using weakness to refer more to its incoordination or sensory loss. So we'll have to clarify that. We want to make sure there's nothing going on in the arms, because that would change our localization, right? No subtle weakness, no pronator drift, no hyper or hyporeflexia. And then we want to examine in great detail, presuming that's all normal, the legs to determine what's weak, how weak is it, are there sensory changes as well, and are those reflexes increased or decreased? If this is really a problem that's been going on for 3 years, we should be getting some clear signs of either spasticity or flaccid weakness here. As I'm talking about all that, I'm wondering, we haven't talked much about the time course here, right? If this is a 3-year problem in the lower extremities, what types of processes would we have on our differential here? And might that guide things we would look for on our exam? Either Nalayan or Shubhangi, what do you do with the fact that this has been sort of progressive over 3 years? What types of things might you consider over that time course?
I think I'm having sort of bias with respect to the canal stenosis part. So if there is a degenerative lesion which is pressing on the spinal cord, or an expanding kind of a lesion, a tumor, or a kind of a meningioma, or any a mass effect. So with respect to the 3 years, it would lead to a progressive loss of a motor function and autonomic dysfunction. But then again, I think I am fixating.
Yeah, no, you're correctly
had a bias
correctly. Yeah, you're correctly fixating on what evolves chronically in the spine, right? Degenerative disease of the spine. He's pretty young, although depending on the occupation, if it's a lot of heavy lifting or other very physical activities, there can be early degenerative disease of the spine. So this could be a degenerative, and we say degenerative, not neurodegenerative, right? Sort of wear and tear arthritis type injury to the thoracic lumbar cord. Most common areas are in the lower cervical and sort of mid lumbar L3, L4, L4, L5, L5, S1, and C6, C7, C7, C8 would be the most common places. Thoracic spine doesn't move very much, whereas the cervical and lumbar areas are much more mobile. So I agree with you, chronic. We would think in the spine degenerative. Some very slowly growing tumor. So a more benign type of tumor that's growing very slowly, like a meningioma you could get. Right, you could get an ependymoma, but what's the one? There's one that likes the conus medullaris, myxopapillary ependymoma. I'm not sure, actually, I've never seen it except on my boards, how quickly it grows, but yeah. What else? So any other thoughts, Nalayan? We heard about degenerative possibilities, neoplastic possibilities. What else would sort of fall into, presuming we're correct in our localization that we're somewhere in the spine, a sort of chronic progressive spinal condition?
Yeah, I was thinking in terms of more indolent infections like TB. Yeah, but that's all.
Like which one? I'm sorry?
TB, tuberculosis.
TB. Yes.
I have a bias there as well.
Yeah.
Basically, some indolent infections could be endemic fungi as well, but some very chronic, slow-growing organism.
Yeah. So, so 3 years would probably be a long time to have POTS disease, but probably not impossible. So yeah, TB would be certainly a consideration. Other infections that can evolve over this time course can cause a myelopathy, HTLV1, now called HAM, HTLV1 associated myelopathy, used to be called tropical spastic paraparesis, to distinguish it from hereditary spastic paraparesis, which we can also put on our differential. So HTLV1 could be on the differential here. And HTLV1 is actually very common in endemic areas, but it's not that common that it actually causes this myelopathy. The myelopathy of HIV, the HIV vacuolar myelopathy, which affects the dorsal columns and corticospinal tracts, just like B12 deficiency does, that is also a chronic myelopathy, though usually those patients by that time are quite ill with advanced AIDS. They have HIV-associated dementia and other sort of signs that they're very chronically ill, which we don't hear here. And then the other sort of very slowly progressive indolent myelopathies we could consider are the inherited degenerative myelopathies. Those are very uncommon, but there is hereditary spastic paraplegia. Presumably there would have been a family history, but maybe he doesn't know, or his parents passed away before they could manifest symptoms of it. And hereditary spastic paraparesis or paraplegia, there's now, I think, 30-something variants of that can have all kinds of other associated symptoms. My recollection, I could be wrong, is that tends to spare the sphincters. It's really a motor disorder. There's also adrenomyeloneuropathy, AMN, which is in the family of adrenoleukodystrophy, but causes a myelopathy and neuropathy. I've only seen one case in 10 years, and that was a patient about this age who developed a sort of progressive spastic paraparesis and bladder dysfunction, and had I think it's the ABCD1 gene or something like this, had that condition, very uncommon, but very slowly indolently progressive myelopathy. So those are also on the differential. So degenerative, neoplastic, some slow infections, and hereditary causes here. I do wonder what to make of his wife having multiple sclerosis. Is that the correct diagnosis, or do both of these patients have some myelopathy due to a common cause, and his wife might have been misdiagnosed? We often see patients who carry a diagnosis of multiple sclerosis who don't actually have it. They've been misdiagnosed because they have symptoms, but maybe not the appropriate scan. So is there some toxin that they could have both been exposed to that could cause a myelopathy, a toxic myelopathy? B12 deficiency causes subacute combined degeneration. Usually there's no sphincter dysfunction with that condition. Usually actually there's not much weakness. The patient's gait is impaired, but it's mostly from sensory ataxia. But if we saw vibration loss and some upper motor neuron signs mixed with lower motor neuron signs, we could think about B12 deficiency. And there are other toxic myelopathies. Well, we won't go down that rabbit hole. We don't have that much time left. Yes, there are other toxic myelopathies too we could think about. Great. So Valeria, tell us what you found on the exam, and we'll see if we're right that we're in the spinal cord or cauda equina, and if not, we'll go back to the drawing board.
Great. So for the physical exam, his temperature was 37 degrees Celsius. His blood pressure was 140/90. His heart rate was 90 beats per minute. Respiration rate was 18. Mostly the general exam was normal, but on the mouth exam, it was noticed some gingival bleeding. And on the neurological exam, the patient was oriented to time, space, and person. He had general mild spasticity that predominated in his lower extremities. He also had increased muscle tone. His muscle strength was 4/5 bilaterally in his lower extremities, and he had also hyperreflexia, clonus, and bilateral Babinski sign, and he also had a left Hoffman sign, but he could walk unaided and no specific gait was noticed.
Excellent. Shubhangi, I think you're up. What do you make of this examination?
First impression, upper motor neuron lesion are taking place all throughout the bilateral extremities. I don't know if the mouth gingival bleeding is related to this or not, but I would like to put it aside for the time being. The vitals seem stable, and if Valeria could tell us that if the test for orthostatic hypotension was done, maybe we can come to know if there's any associated autonomic dysfunction or not. That's what I make of this.
Yeah, great thoughts. Yeah, so this is spinal cord, right? As you said, this is upper motor neuron hyperreflexia clonus, Babinski. I'll ask you about spasticity. I'll ask you both in a moment about the Hoffman sign. If not, I can define that. But yes, we are in the spinal cord as we thought. And then, yes, that's going to be a key question for us, is this gingival bleeding. Is there some relationship between that and the ultimate neurologic diagnosis here? And then, Valeria, was there any, I think we know our localization, so maybe it matters less, but related to the sphincter dysfunction, Subhangi asked, is there any autonomic dysfunction you could find? Was there a distended bladder? Was there decreased rectal tone? Anything like that?
No, the abdominal pelvic exam was not.
Okay. All right. Nalayan or Subhangi, either of you tell us about the Hoffman sign, or should I take that one?
I just know that it.
I think I'll go. So the Hoffman sign is an upper motor neuron.
I think we lost you there in the line.
So okay, from what I know, so from what I know from orthopedic classes, Hoffman sign is for upper motor neuron for the upper limb, and a positive at the level of maybe cervical or thoracic spinal canal as well. So there is a possibility that we have two distinct lesions, one at let's say lumbar and other at thoracic or cervical level, which is causing the upper motor neuron signs at both these levels.
Very good. So the Hoffman sign is like the upper extremity Babinski sign. I know you were both starting to talk at the same time. You cut out briefly, Nalayan, but that's exactly right. Subhangi, do you want to tell us how to perform the Hoffman sign, how to look for it?
First of all, we explain the patient what we're going to do. We take the consent. We sit the patient down. We take I wish I could put my phone down and show it to you. We take.
I'll demonstrate. You can talk. Yeah.
We take the middle finger and we basically on the distal phalange on the nail. We try to do this, and then we see if there is a flexion happening, and so that is a positive Hoffman sign.
Brilliant.
I hope I got it.
That's perfect. Yeah, brilliant, Subhangi and Nalayan. That's exactly right. So this is an upper motor neuron sign you can look for in the hand. And you sort of suspend the patient's hand nice and loose, and you kind of do like you're snapping your fingers on that middle finger. And if the fingers and thumb flex, that's a positive Hoffman sign, and that tells you that you have upper motor neuron signs. In this case, maybe the spinal lesion is a little higher than the thoracic cord if we're getting that. But so there's something in the, perhaps even at the cervical level here. I don't think we necessarily need to invoke two lesions. We could say cervical and it's affecting that and everything below, but you raise an interesting point, Nalayan. Could there be multifocal lesions in the spine here? Okay, so we've localized, so now we know what we need a picture of, and that's the spine, right? We know that brain imaging is not going to help us here. What else can we do in neurology? And EEG is not going to help us here, and EMG is probably not going to be helpful here, right? Spinal fluid, depending on what we see on the spine imaging, may or may not be helpful here as well. And then what are we going to do about that gingival bleeding? Nalayan or Subhangi, any thoughts on how to incorporate that with our clinical assessment at this point that this is a myelopathy?
Well, one theory I had is a gingival bleed could be a sign of systemic vasculopathy. And maybe if we have an extradural hematoma that is constantly expanding throughout the time period, so it could lead to progressive worsening of symptoms as we are seeing here.
Yeah, I think, is there a primary hematologic problem, and what hematologic problems can also affect the spine? So if there's a bleeding diathesis, right, he could also have bleeding in or around the spine. Usually epidural hematoma, hematomyelia, those are going to be pretty acute presentations. So I think that's probably less likely. I have seen very rarely you can get extramedullary hematopoiesis actually in the spine when someone has very severe anemia or a hematologic malignancy, and there's actually a focus of extramedullary hematopoiesis compressing some region of the nervous system. I've seen that maybe once in a sort of CPC context, so I guess that's a possibility here. The time course of the, if the 3-year time course is accurate here in the sense that the patient is accurately remembering this has really been going on for 3 years, it's hard for me to imagine a hematologic process that patient would still be awake and talking to us and doing okay. It has a severe process causing gingival bleeding and a 3-year myelopathy. So I'm not sure what the association could be there. I saw a flyby on the chat, someone saying HTLV1. I know it can cause some T-cell lymphoproliferative disorder. I forget which one it is because I'm a neurologist, but I know that the more common condition it causes is this hematologic one. I don't know if that could present with gingival bleeding or be this sort of chronic in presentation. So if that's the answer here, you all can teach me what that aspect is. But we have a chronic myelopathy, right? So I think we need to look at some pictures and see if it's compressive or non-compressive. If it's non-compressive, are there lesions in the spine that tell us what to look for here in terms of etiology? If the spine looks completely normal, that also, or the cord, I should say, looks completely normal, that can also fit with some of the etiologies. HTLV1, you can see cord signal change. Often you do not. You may see some cord atrophy. And then tuberculosis is always on the differential, whether it's malaria presenting or not in a TB endemic region with a myelopathy. And could TB somehow cause gingival bleeding? I'm sure you can tell me some way that it can, because it can do anything. And there was no sensory dysfunction, right, Valeria? The vibration, all that was normal, just to, yeah, yes. Okay, so sensory was normal. Okay, so we want to see some labs probably to address this bleeding issue, and we want to see some imaging of the spine. So what did you do next, Valeria?
Yes, I can give you some general labs. His hemoglobin was 13.5. His white blood count, hepatic panel, and renal panel, and well, basically all chemistry was normal. An LP was done, and his opening pressure was 14 centimeters of water. It was crystal clear fluid. They were found 10 leukocytes, 100% lymphocytes, 65 proteins. There was 60/80, I don't know how you say it, but like glucose in the LCR, like glucorrhagia. And it was done KOH of the LCR, which was negative. ABK, also for looking for TB, was negative. Tinta China, which I believe is for crypto, was negative. And neurology for BDRL for syphilis was also negative. FTA antibodies, which are also for syphilis, was non-reactive. And HIV was also negative. So, well, chest X-ray was done and it was normal. And an MRI of the spine was done, and I can give you that. The MRI showed atrophy of the dorsal spinal, or the dorsal spine, which radiology put it as expressed loss of motor axons.
Interesting. So for Cryptococcus, did you call it, what was the word you used for the test for Cryptococcus?
I'm not sure.
Yeah.
Tinta China, which is
Tinta
Chinese.
Yeah, this is
Indian
interesting
ink.
because in English we call it India ink stain, and I know in Haiti they called it encre de Chine as well, the Chinese ink. So I don't know why in some parts of the world this is Chinese ink, and in some places it's India ink. In either case, it's a very insensitive test for Cryptococcus. The antigen is the more sensitive test, and cryptococcal myelopathy with no meningitis would be very unlikely. So I think the next ALCO will reveal the final diagnosis is my guess here. So Nalayan, Subhangi, based on this data, what do you think is going on here? And what do you think the final diagnosis is, or what's the test you would send to try to confirm it?
I'll go first, I guess. Okay, so the LP revealed nothing much. We have 10 lymphocytes. The glucose level seems normal. So based on this, I think we can localize it to viral autoimmune or malignant cause. Basically, I'm trying to rule out bacterial cause of meningitis, maybe. We were not looking at meningitis either way, but I think we can rule out bacterial infections in a way. But viral autoimmune and malignant and maybe rickettsial infections are still on the table. Apart from that, atrophy of dorsal column, that makes me think of SACD, subacute combined degeneration of spinal cord. And I think someone also put it in the chat, given the fact the patient might be vitamin C deficient, vitamin B12 deficient can be looked upon. And that's all.
Great. So subacute combined degeneration. It's interesting. It's, in my experience, usually very subacute in the sense that it's pretty fast, faster than 3 years, evolving really over months. And in those patients, although they don't tend to report sensory, they can report sensory problems, but the combined is the dorsal columns and corticospinal tracts, and the nerves can be affected as well. There's usually very severe vibration proprioceptin loss, dorsal column dysfunction on exam, which we didn't hear about. And there's usually actually not weakness per se, that patients are unable to walk due to the sensory ataxia from dorsal column dysfunction. They do have a mix of upper and lower motor neuron signs, but aren't typically weak. So definitely in the differential for a subacute myelopathy, and one with hematologic implications, right? Although it shouldn't necessarily cause bleeding, but usually a little faster, and we should see vibration or proprioceptive loss there. Okay, so a vote for a toxic metabolic myelopathy from Nalayan. Subhangi, what are you thinking here?
No, I need guidance at this point. So I would like you to take the stage. Thank you.
Sure thing. Yeah, so we knew we were in the spine, right? So we took, Valeria and her team took a picture of the spine, right? And we want to first see when we're looking at the spine, so we can divide pathology of the spine. This is used for tumors, but I think useful across any type of etiology. Is the problem extradural, meaning a problem in the bones? Is the problem intradural extramedullary, meaning a problem with the meninges essentially, but not yet in the spinal cord? Or is the problem intradural intramedullary? So extradural versus intradural, and then intradural extramedullary versus intramedullary. So the extramedullary component here is fine, right? We don't see broken bones, we don't see bony destruction, we don't see lytic or blastic lesions in the spine, right? So then we don't hear about the meninges. I don't know if the scan was done with contrast, but usually we'll be looking for contrast enhancement of the meninges or a meningeal mass like a tumor, and we're not hearing about that. And then we get to the cord itself. And for some of the etiologies, if this were an intrinsic cord tumor, right, we should see a mass. For some inflammatory or infectious lesions, we could see signal change in the cord. But actually, all we're hearing about here is atrophy of the cord. So what causes cord atrophy? A degenerative condition, like I mentioned, hereditary spastic paraplegia, the myelopathy associated with HIV. Again, these patients are generally very ill and sort of late stage AIDS, and this patient has a negative HIV test. And then HTLV1, which we've circled around a few times, right? And the spinal fluid is slightly inflammatory, right? We have a mildly elevated protein, usually depending on the lab, 30 to 40 is the upper limit. So that's high, but not super high. And we have 10 leukocytes. We should have 0, although we generally will accept 0 to 5. And so this is a mildly inflammatory CSF. This time course wouldn't fit for an inflammatory condition. Multiple sclerosis, you would get an acute transverse myelitis. Neuromyelitis optica, you would get an acute transverse myelitis. So there's some sort of chronic low-grade inflammation here, which I think brings us back to HTLV 1, but Valeria always has surprises, so we'll see what the final aliquot reveals.
Great, amazing discussion, everyone. So the final aliquot was gene expert. No, I'm kidding. I'm kidding.
Oh.
This is not TV. I'm totally kidding. So the final aliquot was an enzyme immunoassay for HTLV1, which was positive, and also serology in blood that was positive for HTLV1. And this was called out as tropical spastic paraparesis or HTLV1 associated myelopathy, which is really common here in Peru. And actually, Aaron, you totally nailed it with the family history, because his wife also had HTLV1. And actually, this case, I saw it last year, but was actually part of a case report of a family, an entire family of 10 members that had HTLV1 associated myelopathy, because here in Peru, the fact that it is very common to see the mothers through breastfeeding passing it through their children, and also sexual transmission and blood transmission, which is less common. And basically, it is a condition that affects the motor nervous system, and can also have manifestations in the sensitive and autonomic dysfunction, as this patient had. And the association with strongyloides, which a lot of people in the chat were mentioning, and I think it's one of the most interesting co-infections. There are evidence that shows that it is more, the adult type T-cell lymphoma is more common to present in a patient that has a previous HTLV1 infection with strongyloides, and also the hyperinfection of strongyloides is more common when you are co-infected. But actually, the neuro manifestations that we saw in this patient are less common if he was co-infected. He had strongyloides. That was the infection. But yeah, really great discussion, and really happy that you got that diagnosis super fast.
And Valeria, am I correct? I haven't seen too many cases. Well, there are places where I've worked where I think I've seen cases, but haven't been able to test for it. And I've seen only a few confirmed cases. That it's a very small percentage of people who are infected with the virus who actually develop the spastic myelopathy. Is that right? Yeah.
Yes,
and then treatment, my understanding is some people use antiretrovirals, HIV medications, but there's no real evidence for that. Some people try steroids, no real evidence for that. Is that right?
Yes, I believe, this patient didn't receive treatment because he was relatively okay. I believe his family, his wife was worse in the sense that she couldn't walk. So I think she received steroids, but you're totally right that there's no definite treatment.
Yeah, I saw one very memorable patient in Boston from Haiti who actually had motor neuron disease that looked, for all intent and purpose, like ALS, but also had bladder involvement, which would be very atypical for ALS. The neuromuscular fellow and attending did the EMG and said, this is motor neuron disease, but you're right, the patient also has a myelopathy, and the patient actually had HTLV1 associated motor neuron disease and myelopathy. So motor neuron disease has been reported with this as well, sort of mimicking ALS. So, and I think even is there even a myopathy that can be associated? I might be making that up, but motor neuron disease has been rarely reported. Wonderful. Well, very excellent discussion, Nalayan and Subangi, and thank you for this case, you said it was a short case. I promised I would make it long, and I did. And so be great to hear the teaching points from Maria. Oh, Subangi, you had your hand up for a question, or?
Thank you. So first of all, a great case, and this is so rare. There are so many learning points on the whiteboard, and thank you, Valeria. Thank you, Dr. Berkowitz. I'm so sorry. I had a question. But to be honest, I don't know much about this, so I just wanted to know what would be the pathophysiology that leads to the bilateral lower limb weakness and not anywhere else, and from after getting infected with HTLV, like why this localization?
What a great question. I don't know that, and I don't know if patients progress long enough, if it will become all four limbs. My guess is that it's affecting spinal motor transmission, and because the legs are the furthest away, from the brain, there's the most kind of traffic to get from the brain down to the legs. Those are what are affected, but it is called tropical spastic paraparesis, although I guess now it's been changed to HLV1 associated myelopathy, maybe to reflect that it's not always just the legs. Did you find anything on this on your reading, Valeria, about whether patients can have the arms affected, or why, despite being a myelopathy, it tends to affect the legs more? Is that just because it's disrupting transmission enough to affect the legs because of the longer distance of transmission, and just not enough to affect the arms because of the shorter transmission? I don't know the answer. That's a great question. I don't think there's a viral tropism for thoracic cord or lower, just the thoracic cord is the longest part of the cord, and my guess is that it may just more commonly find a home there, but I don't know. Do you know, Valeria?
No, I actually don't know. I mean, I hadn't even questioned that. I thought it was like Guillain-Barré that was like ascending and had something like that pattern, but I will make sure to look it up.
Yeah, hereditary spastic paraparesis, although there's so many varieties, I can't keep track of them. I'm sure some have the arms, also some have cognition, ataxia, other things. Generally, those patients will progress in the lower extremities for a very long time without, in the few cases I've seen, any involvement of the arms. So my instinct, my guess, although it's not scientific, is just that you're disrupting these pathways a little, but not fully, and it's there's enough function to get to the arms, but maybe not enough to transmit all the way down the length of the entire corticospinal tract to get to the lower spinal cord. But I don't know. Great question. No idea. Those are my favorite questions, and I have no idea the answer. Shows us how much we still have left to learn, isn't it? Great. Well, thank you for all who have stuck with us for the whole hour. And Maria, tell us some teaching points from this case.
This was so good. Thank you, Welle, and the people who discussed. I loved, there were so many teaching points. First, we started with having a chronic neurological disorder, which, we tend to think about degenerative and it's fine. So the musculoskeletal components. You can also think about indolent infections and slowly growing mass that have a tipping point from being smoldering to the time they present. And then the chief concern was just very interesting with frequent stumbling. And, you have to remember that gait is a combination of a lot of different inputs and outputs. So when you're evaluating tons of things from ocular, vestibular, higher order motor function, cerebellum, the peripheral nervous system, both motor and sensory, and even proprioception, which is what you test with the Romberg test. People a lot confuse it with cerebellar testing, but you're really checking for the proprioception. And then there's also non-neurological problems. So you have orthopedic causes. You can have problems with the vision that can make the patient fall. Also the environment, especially with older patients, maybe not in this patient because he wasn't particularly old, but when people start getting dementias, they leave stuff all around, and they're it's more hazardous for them to fall. Also think about alcohol or even polypharmacy, maybe something in their pressors that makes them more prone to syncope or falling. And then we layer that with bilateral lower extremity weakness, and that has a very interesting localization pearls. So first you can divide between upper motor neurons and lower motor neurons, and then think upper motor neuron, brain, and spine. Brain is a bit tricky, you know, we don't usually associate it with bilaterally lower extremity, but think like the homunculus, the most medial part is the legs, so you can have like medial processes affecting both sides of the brain, like ACA strokes or parasagittal meningiomas. With lower motor neurons, you're in the roots and the nerves. And then if you don't have signs with reflexes and the weakness is more proximal, you may think about muscle disorders. In this case, we did have like upper motor neuron signs, so everything goes up, increased tone, hyperreflexia, upgoing tone, which is like the Babinski, and we even had like the Hoffman sign, which is like the upper extremity Babinski. And we also had like very particular symptoms, so autonomic features that's localized to spinal cord or cauda equina and associated sensory loss. You know, we don't localize that to muscle or neuromuscular junction, so we need to localize that to nerves or spinal cord. And then with that, we knew we had like a problem with the spine. So Valerie and her team took like an image, and we did have like this I had never seen that before, atrophy of dorsal spine, which can be caused by like hereditary neurodegenerative disorders, HIV and HTLV1. And the final diagnosis was HTLV1 myelopathy, which I've never seen a case or heard about it before. So it was amazing teaching points for me. And I hope that it was amazing learning for everybody.
Great, thank you, Maria. And we all hopefully noticed when Maria first heard HTLV1 in the teaching point, she followed with, wow, www, which was a great teaching point. Yeah, thank you so much, Valeria, for bringing us this case. We all learned a lot about the approach to gait, to how to diagnose a myelopathy, to the very broad differential, which can be broken down by time course, and to think about in endemic contexts TB, but you brought us, it'll be TB next time, you skip TB for one. But HTLV1 in endemic regions, I think the areas where it's the highest incidence, my understanding, is in the Caribbean and in Japan, actually. But now we know in Peru as well. And just the other clue here of the family member with multiple sclerosis, whenever I hear that, I say, tell me what their symptoms were, because it may be a different disease. Obviously not a herited disease here in a spouse, but some local factor, toxic or infectious. Great, well, thank you again, everyone. I'm sorry I will be missing you all very much for the next 3 weeks. So I'm teaching the first year medical students and trying to prevent neurophobia rather than have to remove it later by teaching the first year neuro course here for 3 weeks. But I will look forward to seeing you in June and hope you have many wonderful non-neurological discussions in the meantime, or maybe neurological ones still, because neurology is everywhere. Take care, everyone. Have a good day, night, week, and see you soon.
Thank you so much.